So good morning, everyone. Thank you for tuning in, and I hope this turns out to be an informative session for everyone. I was thinking that um, I wanted to introduce this by way of saying this is the latest information available, but by the end of this session, there'll be all new information. It's so rapidly changing. Um, I was going to make a few slides, and I only really made 2 slides, which I'll share with you later, because because it's changing constantly. It's constantly, well, even among us in healthcare, we're always asking each other, what is the current recommendation about this? And it's like, what time is it? So um, it's really a work in progress. Um, Obviously, you all have heard a lot about the coronavirus. Just to give you, and I gave a talk about this several months ago. Just a quick refresher. This coronaviruses have been around a long time. This particular one managed to change in a way that made it highly infectious, and meaning that it can spread from people to people, and also highly dangerous. We've been infected with coronaviruses many times. They typically cause a upper respiratory infection, but this one changed in a way that it could attach to our respiratory tract and create an immune response that, depending on the person, could either be life-threatening or so minimal that you don't even know that you had it. And this is not unusual. People get influenza and have a mild case, and people get influenza and get sick and die. So that's not anything unusual about some viruses. This is being studied in great detail, and there's always some new information. You have to be very careful about medical reports about this thing. Scientists discover a small thing, and then they have to put into context. So if that the virus does this, or this strain does that, or this vaccine has this problem, or whatever, you really have to take it as with a grain of salt. So that being said, I wanted to focus today, and they've asked me to focus today on the vaccines. I'm going to share my screen here. I'm going to try to. Let me go back to here. Oops. And try with share screen. Let me see. Here we go. Share screen. And let's see if I can go to my. There we go. Now I'm going to minimize this so I can show you everything. These are the ones that that are more prominent. The first two, the Pfizer, BioNTech, and the Moderna, are out and about. People are getting those. Tasha and I both got the Pfizer vaccine. A number of people are getting the Moderna. AstraZeneca is the data's out, and and I'm not sure if as of this minute it's been approved or not, but that's the next one you'll be hearing about. The Johnson & Johnson is being worked on. This Sinovac comes out of China. So here's the thing: these vaccines, this technique is not actually a new technique. A lot of people have said, "Oh, I don't trust it. It's a brand new thing. They developed it really rapidly." But this technique of using messenger RNA to deliver instructions to your cells to develop, so you can develop an immunity, has been around since the Ebola virus. I think it was AstraZeneca, if I'm not mistaken, but one of them had developed the Ebola virus vaccine this way. This is about 10-year-old technology. What's new is that they identified the genetic information that codes for the production of the protein that makes the spikes on the outside of the virus. That's the part that our immune systems react most to. And with the modern genetics, they're able to actually create a little strand of RNA that will have the instructions for this particular spike protein. The RNA from the Pfizer and the Moderna are not exactly the same in terms of the amount of letters. They've created it themselves. So what happens with these two is this little bit of messenger RNA is wrapped up in a little bit of fat, and they inject it into your muscle, and it gets into your various cells. Our cells are designed to pick up fat. We have these little fat receptors. That messenger RNA is released inside our cells, and it begins to take up all the cellular mechanism to create the proteins that would make up the spikes for the coronavirus. Now, because we don't have any virus in our cells, no virus is actually formed. These little spikes assemble themselves into basically a spike. The little components make themselves into a little spike, and then they are released from the cell, and our immune system looks at them and says, this is not good, and begins to make antibodies against it. As I've noted, the Pfizer one has to be stored at like minus 90 degrees. So it's tricky and I don't know why exactly one has to be really cold, another one doesn't have to be, but in fact, that's the way it works. The Moderna one is very similar, little messenger RNA, and you can store that in a regular freezer. The AstraZeneca one has a different approach. So in order for us to make the little proteins so that we will develop an immune response to them, it has to get into our cells and then into our body. So AstraZeneca has taken an adenovirus. Adenoviruses cause colds. We've all had bunches of them. They inactivate it so that it can't breed itself and cause us to have a cold. And they put a little strand of regular RNA into it. And that adenovirus does what adenoviruses do. They attach to our cells and they inject their genetic material into our cells, and then it reproduces in there. Now, in this case, the adenovirus will not make itself, but that single strand of RNA will then code for the production of the spike proteins, which self-assemble, are released into our bloodstream, and our bodies develop antibodies to it. The Johnson & Johnson is a very similar one. It's a modified adenovirus. That one also can't really reproduce very much, so it's the same basic idea. I think the advantage of these two is that they can be stored basically at normal temperatures and can be effectively delivered without having to have special requirements. These are probably ones you're going to hear a lot about over the next 6 months. I would bet that probably not most, maybe half of the people who get vaccines are going to get those. People who live out in areas where you don't have refrigerators or deep freezes, people out in the remote parts of various states and remote parts of the country will probably get those because they're a lot easier to transport, similar in other countries. The Chinese one is one, I haven't been able to get a whole lot of actual data on that, but what they have done is they've actually taken the coronavirus and inactivated it, and they inject that into you or whoever, and you develop an immune response just like you would if you had an actual infection, but this doesn't cause an infection. I haven't seen data on that yet, but apparently it's supposed to be really very effective. Hopefully there's nobody, this worries me just a little bit, but I may be, just as a physician who's seen this happen in the past, when inactivated viruses have been used in vaccines, sometimes they don't inactivate them correctly and people actually get sick, but we'll see what happens with that. And then Novavax is interesting. I think sometimes that scientists sit around and say to themselves, what can we do that's really cool? When they talk about this one, what they do is they take a virus with the genetic instructions to make the spike protein, and they actually have it infecting a moth. The moth makes the individual spike proteins, and they essentially collect all these spike proteins, and they put a little chemical on it so our immune system notices it better. And then they inject that into the person. So you're injecting the spike proteins with what we call an adjuvant that stimulates the production of antibodies. And this has been shown to be 90% effective against the South African strain. Now, I'm going to stop sharing for a couple of minutes here. They talk about this vaccine is 50% this, 90%, 65%. They're having big arguments and discussions as to whether the vaccines, the Moderna and the Pfizer that are a 2-shot series, should we just give 1 shot and not save the 2nd shot, just get everybody vaccinated? And I would, if I were in charge, that's what I would do, because we think that, geez, if I can get 95% protection, that's better than 60% protection. But if 70% of the population has 60% protection, that's pretty effective protection. Flu vaccine is only about 70% in a good year and maybe 50% in a bad year, and it still reduces the incidence of influenza and it reduces the incidence of hospitalizations and respiratory complications. So even partial effectiveness is good. And in England, they're actually thinking of making that the policy to just get as many people the first vaccine. The big question is how long afterwards is it okay to give the second dose? And at this point, they seem to think that up to 6 months might be reasonable. So, so don't get excited or worried about one vaccine is 70% effective versus another which is 95% effective. Any vaccine at all is going to be better than nothing. The most important thing, rather than each of us getting our individual vaccines and how much it's going to protect us, the more important thing is the more people who are vaccinated, the better. So then the next question is going to be, what about when are we going to get the vaccine? And it takes a while to produce these things. And the way this is all being done is the federal government purchases it, ships it to the state governments. The state governments then ship it to the various places where it's going to be administered. And then those places try to get people lined up. At Penn State Hershey, we have a limited supply. We've gotten pretty much, I think, about 70% of our staff who are willing to have the vaccine vaccinated. Now they are trying to get something like 30,000 people over 65 that we take care of vaccinated, but they can't just open it up because you'd sign up for it and you might run out. But they do anticipate within the next month or so to have enough vaccine that they can actually have vaccination clinics where people can give themselves an appointment and actually come in and get it. So we anticipate that'll be happening soon. So that's kind of the overview. At this point, let me open it up to questions and just address the stuff that you may want to know. And I also have a link that I'll show you in a little bit where you can go to the Pennsylvania Department of Health, and it will show all throughout Pennsylvania where the vaccines are being administered. And you can kind of click on it and find out what the information about them.
I have a question. Vaccines for the regular flu, I believe, change year to year because the flu's a little different year to year. How about this vaccine? Would you anticipate having to change the formula year to year?
Good question. Flu virus is different because there are different strains of flu. You may have heard or read that have them referred to the H1N1 or the H3N2 types. That H and the N refer to particular proteins, hemagglutinin and neuraminidase in the flu virus. There are, I think there's like 7 hemagglutinins and like 17 neuraminidase types. And flu viruses can infect horses, ducks, and other birds, all sorts of different animals. The reason that the flu mutates is, number one, what we call minor mutations are due to just transcription errors. As the genetic material is being reproduced, it makes a mistake. The bigger ones come from the fact that, say, a duck may get infected with both a human flu and a bird flu, and you get the genetic material mixed up in a cell and the DNA crosses and they get pieces of the different ones, and then it turns it into an entirely different virus. Coronavirus is not like that. Coronavirus does infect other animals, bats for one, and a couple, I'm forgetting off the top of my head some of the other animals, but there hasn't been yet too much information about about that kind of change. It's a more stable genetic material. There have been changes, as you've heard. You know, they've got the South African one and one in Europe and so on that are a little bit different. But at this point, it looks like the vaccine is still pretty effective against it. The key with this, because it's not widespread among animals that we interact with on a regular basis, if we can just get it under control so that people stop spreading it around to one another, and the vast majority of the population is immune, it'll go away. So in the best case scenario is everybody cooperates, gets vaccinated, it stops spreading around, and it shows up in pockets here and there. The World Health Organization would keep track of where it's showing up and then go in there and take care of it, like they do with other diseases like polio and so on. They look for pockets of it to show up, and they go in and they try to get the population immunized so it stops spreading around. So I don't anticipate that there'll be major changes, but again, there's really not good information. And as I am not a microbiologist, I wouldn't go around quoting and saying Messmer says it's never going to mutate to a big. I don't know that, but I'm anticipating that it probably won't. Let's see. Somebody wrote, if you were in a group of people where everyone's been vaccinated, do you still need to wear a mask? Oh, that's a great question, and this is causing a lot of confusion. The vaccine reduces your risk of having a serious infection, or even, and actually it reduces the risk of you having a mild infection, but it doesn't stop you from being infected. Now, by infection, I mean the virus gets into you and breeds and causes you to be sick. The vaccine will help to reduce that, but you could still get the virus into your nose and throat. So you can still transmit the virus to other people. So now if you're in a, so Pam says if where everyone has been vaccinated, you know, which vaccine did they get? Is it with 50% effective or 100 or 95% effective? One could argue that if everyone had 95% protection and everyone was in this group and they were totally vaccinated, you could argue that you don't need to wear a mask because you're all pretty well protected. But we don't, you know, we don't know. We don't, you'd have to draw blood, check the antibody levels, make sure that they're all okay. Yeah, theoretically, it probably would be okay in a small group. I would think when you're out in public, you should still wear a mask because you might have the virus in your nose and throat. And you don't know if you're going to come in contact with someone who's not immunized. But in theory, you could probably have a small group where everyone's fully vaccinated and get by without the masks, and it would be a small risk. I wouldn't say a zero risk, but it'll be a small risk. That's probably not going to happen except in your home. Any other questions? If you get vaccinated though and you're out in public, you definitely need to still wear a mask because you just don't know if you're spreading the virus around or not.
On that subject, I've been in grocery stores where they only have shields on the employees. I go into a Walmart and there you'll find people without masks. You'll find a lot of people not covering their nose. And then you wonder, you know, there could be medical reasons why somebody doesn't wear a mask, but you don't necessarily know whether that's the case or not. So any comment you have on wearing masks?
I have no idea what would be a legitimate medical reason other than claustrophobia for not wearing a mask, and claustrophobia could be dealt with a different way. People who say I have a doctor's note have a funny doctor because there's really no reason not to wear a mask. People who say, well, I can't breathe, and that's more psychological. It's fear, anxiety. You know, I don't like having a mask on too. It makes my nose run and my glasses steam up. But there is no good medical reason for not wearing a mask. The mask, a good mask that's tightly woven or is a medical grade mask or even an N95 mask, dramatically reduces the virus spreading out. It gets trapped in the material. The N95 mask, if it's tight up against your face, will also help to protect you. The shield is only to protect the wearer. You can still spew out virus around the sides of the shield. So in the office, when we are in contact with patients, we wear the masks, but we also put glasses on or face shields to protect us in case someone coughs at us or sneezes or whatever. So the shield, someone wearing a shield, it does not substitute for a mask. It doesn't protect, it doesn't keep you from shedding virus into the environment.
You can read the chat. Yeah, there you go. There's two in chat.
Yeah, distribution is molasses. Yeah, it's slow. Could it be better? Probably. I'm not in the meetings where they decide how to send these things out. I suppose it could be better, but the fact of the matter is that Pennsylvania can't distribute them until they get them from the federal government. And if I remember correctly, the Pfizer put out about 100 million doses, but they haven't been distributed. yet. I mean, they guaranteed 100 million doses, and then they just put an order for another 100 million doses. But they aren't in boxes in people's labs and people's areas. They are being distributed. I think that's the point that's been missing in a lot of the information. It's the vaccines are coming, but they aren't made. They aren't out. And it would be nice to be able to, it would be better, I would think, if they could distribute them directly to the states. But again, I'm not involved in the supply chain discussions there, so I don't know if that's even possible. I was late. Did you already cover the best ways to get the vaccine for 75 and over? I'm going to cover that a little bit about the vaccines, the best ways, the best ways. Let me just do. I'll share my screen again for a moment and go to the next slide. Here we go. This is being recorded, so it should be available. But if you want to take a picture of this or somehow take a copy of this, or you can just go to www.health.pa.gov and search for COVID-19 vaccine providers. There's a map. Let me see if I can actually click on that and show you what it looks like. Yeah, here we go. I'm hoping you can see this. So if I make it bigger, come here. Nope, they don't want to go to Virginia. We don't need to worry about Virginia. Come here, Pennsylvania. Now I'm lost.
I don't think we see your mask though. I mean your map.
You don't see the map.
No, we just see the website.
All right. Well, sorry about that. Let me see this. Let me stop. New share. Let's try this. How about that?
Yeah.
Oh, there we go. Now we're going to make it a little bigger. We're going to slide over here, make it a little bigger, slide over here. When you get there, you can click on these little areas and you'll see, for example, there's a Weiss Pharmacy. There's the Weiss Pharmacy in Hummelstown, for example. They have a website, they have a phone number. You would just have to call them and say, do you have the vaccine? Let me make it a little bigger yet. And here's Hershey. Somewhere in there is probably the medical center. Nope, that's the Hershey gift pharmacy and gift shop. Probably right next door is the medical center. Yeah, there it is. So there's a number. There's the website, pennstatehealth.org, coronavirus/vaccine. When you click on that, you'll get the latest information as to where where and when it's going to be available in each of those places. I wish it were easier than that. Hang on here, just stop sharing. I wish it were easier than that, but this is a whole new process for people. It would be nice to, it would be nice if everybody could be lined up and get the whole population immunized immediately. It's just not possible to make that much vaccine that quickly and get it out and about. If you are wearing your masks, if you're keeping your hands sanitized, if you're avoiding crowds and avoiding people without masks, your likelihood of getting infected is reduced. And when you get your vaccine, it'll be that much better. And I think I'm understanding that this should become pretty much readily available by mid-March. Would that it had been available back last September, that would have been great, but nothing I can do about that. My own personal opinion is they should just give it to everybody. It would be nice, it's not sure focused on people who need it the most, but it would be nice to just give it to everybody, because as I said earlier, the more people who are protected, the better it is for everyone. If I were doing it, I would just say line up and give it whoever, because younger people can spread it around just as much as older people can. And if a lot of the younger people are protected from having it, they're less likely to be, they're less likely to have that much virus in them. I mean, like I said, you can still have the virus in your nose and throat if you've had the vaccine. The thing is, you'll probably have a lot less of it. If you actually are not protected, you can have a significant amount of the virus. You can actually be infected with it and be having coronavirus, but you may not be terribly sick from it, because there are an awful lot of people running around who have antibodies who didn't even realize that they had been sick. Keep coming up with dead ends. Yeah, it's true. I mean, there aren't any. The problem is that all those places are going to be places who have vaccine, but they don't currently have vaccine.
I just had a quick question about where can you go to get tested at the med center?
It's becoming more readily available at the med center. At this point, we're testing people who need to be tested because they're sick. It's getting more easily available. It was a 4 or 5 day long lag period, but now we can pretty much get it overnight. But we're not just doing it randomly at the medical center yet. But you can get tested at CVS, a couple of the places. Not every CVS can do it. You have to have the app. You have to download the app, the CVS app. You log in, you register and everything. But you have to have a symptom. They're not doing it on people without symptoms. So if you feel a little bit like you've got a little ache or you got a little bit of a cough or a stuffy nose, you can put that in and you can get an appointment to be tested. A lot of the urgent care centers will do it too. To the best of my knowledge, there's no one doing routine asymptomatic COVID testing, probably because the labs would be overwhelmed.
Right.
As more and more of the reagents and the testing materials are available all throughout the country and locally, it will become easier to get a test. There's a rapid in-office test that a lot of physicians' offices are getting. The only drawback with that is the false positive and false negative rate. So the easier it is to do the test, the more likely it is to be not as accurate. So the problem and the difficulty here is if let's say it was readily available to anybody anytime to be tested, but the accuracy is not all that great. The problem is that some people would say, well, I don't have the virus, so I don't have to take precautions. But they might actually have the virus because it would be a false negative.
Right.
And that would cause more spread of disease. And this is kind of why they've limited it to people who are symptomatic or people, it's pre-admission to the hospital, pre-admission to long-term care facilities, pre-admission for surgery. Those people are being screened without symptoms because we want to try to be as careful as we can that we pick up the people who have the virus.
I just wanted to add that I did, since I was traveling and then I quarantined, I did pay $140 at the CVS in Hummelstown and could get a test, because you had to test negative before.
Right.
So you can pay for it apparently. And
Yeah,
just people who aren't sick, you don't want to lie and say you're sick when you're not.
Right.
Do you know which kind of test it is for that CVS runs? Is it a PCR test or was it the rapid?
No, I believe they're all PCR tests that are being done. When you go and you pay some real money for it, I believe they're all PCR tests. In fact, if you're traveling any place, they want you to have had a PCR test.
Is that the one up your nose or the other one?
You can.
Oh, sorry. Okay.
You can do it either up your nose or your nasopharynx all the way in the back. It's still PCR tests.
Yeah, mine was a nose swab and I paid $140 for it. That was the one I was given.
I'm glad you said that because I didn't know what they were charging.
Yeah.
Back in September, Tasha and I went to Aruba, and you had to have a negative test before you went there. And if you didn't have a negative test, they did it for you in the airport for $75. And so that's how we had it done. And that was a nasopharyngeal swab. Both sides. They did both sides.
Mm-hmm. Mine too.
Yeah.
I just wanted to say we traveled to Florida over Christmas, and we had a free Rite Aid test in Lancaster, the PCR.
Yeah, so some places will bill your insurance, and your insurance may cover it. It all depends on your insurance.
Right.
So they'll take your insurance information, and they can. The nice thing about pharmacies is they can often tell right away whether it's going to be covered, which is something that all physicians' offices should be able to do. But for whatever reason, I don't understand why we still can't do that. But don't get me started on that topic.
And I think a lot of people just say they have a cough and they get a free test.
Well, I always have a little bit of a cough from allergies.
Yeah, right. So. Stuffy nose.
Okay. Shouldn't we help the older folks get it first to prevent stress and worry? like I said, it would be knowing the way these diseases work. In my opinion, I'd give it to everybody. I don't care how old you are or what's wrong with you. Just get as many people vaccinated as possible, because the more people vaccinated, the less likely we're going to see it spreading around. If we restrict it, we're giving it to older folks first. We're giving it to people in communities, which, like long-term care communities, because they're in groups that are more likely to spread it among themselves. I understand emphasizing that. I understand emphasizing healthcare workers who are constantly being exposed to it. But other than that, I would give it to everybody, just because the herd immunity, the more people get immune, the less likely anybody's going to get sick. And does the vaccine have impact on non-symptomatic carriers? Well, there's no such thing as a carrier that we're aware of. You're either infected or you're not. I don't know that there's any evidence. I can't say that it's not true that there's not a carrier, but I don't know that there's any evidence of actual carriers, like people can carry hepatitis virus, for example, and not have symptoms. But I would think theoretically that if you got the vaccine and you had the virus in your nasopharynx, that eventually, because it wouldn't be able to infect you, and if it did get into your cells and reproduce, your antibodies would again neutralize it. That eventually you'd clear it. So theoretically, getting the vaccine will eventually allow you to clear it from your nasopharynx. Although I don't know how long that takes, and I'm not sure they've been able to test that. I'm sure somebody's looking at it, but I don't think that anybody has that information exactly. The after effects. Oh, the after effects, that's a whole topic. So I'm glad you brought Sally. It's interesting about this. When doctors say it's interesting, that means it's bad for everybody. So a lot of people get this vaccine and have no problems whatsoever. Some people get it and get a mild symptom, and some people get it and they get really significant reactions. And a lot of that depends on your own body's immune system and how you react to things. We think actually that a lot of the reactions are to the liquid that the vaccine may be in. There's polyethylene glycol is what this stuff is in, and polyethylene glycol is in everything. It's in hand cream. It's used in the number of foods that we eat that might have polyethylene glycol in it. It's not something that normally we would react to unless you inject it into our bodies, and some of us will react to it more than others. There are people who can be sensitive if it's in a skin cream and they rub it on, and they'll get a local reaction. So if you happen to be sensitive to polyethylene glycol, you're probably going to have a bad local reaction. I don't think it's it's the vaccine that people are reacting to immediately, because the vaccine disappears very quickly. It gets into the body, it gets into the cells, you start producing the proteins, and then the vaccine itself is pretty well gone. At that point, your immune system is turned on and producing its own antibodies. And then when you get the second shot, it kind of boosts the effect. If you get a feeling of being ill, like aches and sore throat and so on, you might actually be responding as though it were an actual infection. There are some people who get a delayed reaction. So you get the shot, you're doing okay. 5 days later, you get a big red arm. And that's probably reacting to the fact that you got that stuff into those muscle cells up there. Your antibodies are beginning to attack it. So I tell people, if you're worried about a side effect, before you go in, take an antihistamine. You can take Benadryl, you can take Allegra, Claritin, any of those. Take a couple of Advil if there's no reason why you shouldn't be taking Advil, or take Tylenol if you can't take Advil. Get that beforehand, and then just take it for a couple of days. And I think that helps to reduce the reactions. Now I got the first shot, and I had the Pfizer. And I'm a case of one. I had nothing. I couldn't even. It was milder than even the flu vaccine. My arm didn't hurt. There was nothing at all. When I got the second shot, I woke up the next morning with a headache. I don't normally get headaches. It wasn't too bad. And I thought, now, what did this come from? And then I realized it must have been the vaccine. I took a couple of Advil, and that was the end of it. No further side effects. Most of the people I work with had very little reaction, but one of the nurses ended up getting infected, and I think it was because of contamination from the needle, because she had a local cellulitis and had to have an antibiotic. That was an oddball thing that I think was related to somebody either not cleaning off her skin properly or who knows what. The anaphylaxis, the severe can't breathe, has to get adrenaline shot, is peculiar to people whose immune systems are like that. There are many people who have anaphylaxis to shrimp or have anaphylaxis to aspirin or to a particular antibiotic. And that's hard to predict. We don't have any way of identifying those people. We will one day, that we'll be able to look at your genetic code and tell you exactly what you're going to have problems with. So that's why everybody waits 15 minutes. Typically, if you're going to have anaphylaxis, it's going to show up within 15 minutes.
I had the same experience as you with the Pfizer vaccine. So no symptoms at all, not even a sore arm with the first day or the first dose. The second dose, had a headache. My arm was a lot more sore and some joint aches, and it went away in exactly 48 hours. Like,
Yeah.
oh, I actually feel like instantly better.
The overwhelming majority of people have tolerable side effects if they have any side effect at all, and self-limited, and usually manageable with aspirin or Tylenol or Advil. And if there's any itching involved, an antihistamine. Serious side effects are very minimal, very small percentage, like 1 digit or less, 1% or less. So don't let the fear of side effects stop you from getting the vaccine. Let's see. Once the virus is under control, at what point will mask wearing not be necessary, and who makes that call? Yeah, I'm in charge of that. No, I wish I were. Yeah, at some point when the public health people start to look at the rate of new infections, the rate's going down. If you watch the CDC and even the local paper, New York Times always publishes that the rates of new infections are going down. Why? I don't know. Maybe because people are finally getting serious. But when the rate of new infections drops down to a very small number, and I don't know what that number is going to be, and they're not finding, they'll go around and randomly test people to find out if it's showing up. When the prevalence of the virus is below a certain amount and the rate of new infections is below a certain amount, at that point, public health people will get together and say, we think that it's okay to now open up restaurants, have in-person churches and singing and all that sort of stuff. Who makes the call? If this were a different country where the government was a little more authoritarian, the central government would make the call. Here in the United States, somebody will make a call and everybody will debate it for the next 2 months. And one city will say no, and another city will say yes, and it'll be all over the papers. And the public health people will be arguing as to who's right. So who makes the call? But like for example with Derry, the session has done just an amazingly good job of keeping everybody informed and protecting everyone. And I think what'll happen is they'll look at the data, they'll talk to some of the physicians around and get opinions and make a decision. And everybody will try to, if you're a little more conservative about protecting people, you'll hold off a little bit. And if you're a little bit more like, well, we're just going to trust God to take care of us kind of thing, they'll do it a little earlier. But I don't know who's going to make the call. It's going to be a combination of public health people at the national and state and local level to decide. And it's possible that you might see things opening up in one state, and in the adjoining state, you might not see it. That raises the question about travel. So for example, for Pennsylvania, the governor says if you leave the state and come back, you have to have a COVID test. I don't know how many times that's being done, but so that could happen. They might say that, Pennsylvania is great and you can do anything you want and everybody's free to be open, but you have to be tested before you come back. So I don't know, there's all sorts of options, but really it's going to matter. What's going to matter is that the rate of new infections is dramatically lower and the prevalence of the virus in the community is low enough that the public health people do the calculations, because there's some math behind this, and say it looks like it's safe enough. Let's see. Well, your thoughts about getting a different second shot? Yeah, it's a good question. The problem with science is that you can have an opinion, but we like data, and they are not going to test that at this point. There's not enough vaccine to go around to take 10,000 people and give them one dose of one and another dose of another and see what's happening. but my guess would be that it would be fine. My guess is that if you got the Pfizer vaccine first, and then later when the Johnson & Johnson came out, which is an entirely different type, and got that, you'd probably be just as well protected as if you got two of the same. But the problem is that that's just an opinion. It's not based on science. There's no data to support that opinion. It's simply an opinion. And so I don't know. And we may know one day, only because there'll be some people who accidentally got a second dose from a different strain, and they'll look at those people and see how their antibody levels are. But I can't tell you that there's any good science that says it's okay, but it makes sense to me that it would be okay. We got tested 15toknow.com. Interesting. 15 minutes. We had them in Camp Hill. Drive through. Oh, 15toknow.com, $75. Camp Hill, Maryland. Says if you all look at the chat here, there's something that's interesting. I may look into that. That's probably a rapid test that may have a certain degree of false negative and false positive. Yeah, booster shot. That's also a good question. We don't have a scientific answer to whether we're going to need a booster shot. What'll happen is, let's say we get this pandemic under control and we've gotten rid of masks and we're back out and having groups in public, and no more really restrictions. They're going to continue to monitor the new infections. And if they start to see new infections come back, they may recommend a booster shot. What they'll do is they'll look and see the people who got new infections, did they have a vaccine? If people who had the vaccine are showing up with new infections, we'll probably be doing boosters. If people who are showing up with new infections had not had the vaccine, they might say, get it. It's a good idea to get it, but if you didn't get the vaccine, go ahead and get it. So I don't have the answer to that. We get we get boosters for tetanus, for example, because we know that your immunity drops off after 10 years, so a little bit. It doesn't drop off all of a sudden, so we give boosters for that. We give boosters, we give people, we give older folks an immunization for shingles because the virus lives in our system, but our immune systems are not as strong as we get older, and the virus can reactivate. So we give a booster to the immunity to try to keep us from getting shingles. The flu changes every year, which is why we get a different flu shot every year. So we don't know what's going to happen with the COVID vaccine. The ideal is that it would go away and just go away and be away. For example, smallpox. Nobody gets a smallpox vaccination because the World Health Organization and local and countries have worked hard to eradicate it. So smallpox no longer exists, and we don't have to get smallpox anymore. Polio, we still give polio vaccine to children, but polio shows up in pockets of people who haven't been immunized. And we don't necessarily give boosters again unless, if people are showing up with polio vaccine, they find out where it is and they go to that area and try to get all the people who haven't been vaccinated. But COVID's different. We don't know what the answer to that's going to be. A lot will depend on whether it shows up again after a period of time. Let's see, should be 1 to 2 weeks after the second dose to maximize immune second shot. Yeah, so the issue is as to what's the best timing. They look at what your immune response is. You're making antibodies and so on, and it's a little bit complicated. The way this works is the thing you get allergic to is picked up by one particular type of immune cell, which kind of processes it and puts little markers on the outside of its cells, and then other cells come along and recognize it and say, okay, I got to get to work making antibodies, and they start to do it. And it sort of follows a phase, and when you reintroduce the thing that you're responding to at a certain time period afterwards, you get a better response. They look at various scenarios of when to give the second one, and they kind of look at what gives the best response, and that's why it's recommended at a particular time. If you were a little bit later, it probably would still work. They're talking about, maybe 6 months would be okay. You're going to get a response if you get a second dose. Is it going to be a maximum response, or is it going to be an adequate response? It'll probably be an adequate response. It may not be a maximum response. So But don't really don't sweat these little details. I mean, if you get 2 shots of the Moderna or the Pfizer, if you get a single shot of the other one, you're going to get antibodies and you're going to be protected to a certain degree. But even if you got the 95% effectiveness, 94% effectiveness, I would not walk around among a bunch of people who have COVID vaccine, because it's not absolute 100%. You know, you might still get infected. And the problem is that if your body responds to the virus in a bad way, all it takes is a little bit of infection for you to start to get problems. So you can't walk around and say, hey, I'm okay and I can do whatever I want. If your only concern was about yourself, you're still taking a risk. It's like sort of like driving and saying the airbags will protect me, I don't have to wear seatbelts. You know what I mean? It's not quite the same thing.
Yeah, I think the question was, you know, how long after the second shot is it effective? And I think you still need like another week or 2 after that second shot to reach the 94%.
Yeah, I don't know that they've actually looked at, and there's probably data in one of the labs as to what the best response rate is. But again, if you miss it by a week, don't sweat it. You're still going to get a response.
Right, but it's still, even after you get the second one, like you still need to ramp up your immunity to get.
Yeah, it takes a while to, right.
So, at least.
Oh, I see what you're saying. Yeah, it does take a couple of weeks to get the antibody levels up to an adequate amount. Exactly. Anything else anybody is wondering about?
I saw that one of the questions in the chat was, what about pregnant women? I'm not sure you answered that.
Yeah, I did. I'm sorry. I forgot all about that. It was that scrolled all the way up past my vision. It's being recommended that that pregnant women get the vaccine. The problem is it hasn't been adequately studied. There's no good reason for us to think that this would be a problem for the babies, but again, it hasn't been studied. If you are pregnant or someone you know is pregnant and you're concerned about it, as long as everybody around, you know, as long as the rest of the population is getting immunized, you can probably hold off a little bit. But we think the big problem would be if you have a serious allergic reaction to it. You know, that's the problem. If you have anaphylaxis, that's not good for a developing baby. If you are generally in good health, if you've been tolerant of all sorts of vaccines, you haven't had bad reactions to drugs in the past, and you happen to be pregnant, and you're likely to come in contact with it, it seems that the better decision is to go ahead and get the vaccine. But the problem is that, again, that's kind of like what they call expert opinion. It's not based on science. It hasn't been adequately tested yet to see. There will be data because there will be, you know, after millions of people get the vaccine, there's going to be some women who didn't realize they were pregnant at the time they got the vaccine. This is always tracked for new drugs and new vaccines and so on. When someone gets it and then finds out they're pregnant, these things are reported, the data is collected, and then they look for problems afterwards. They're not going to take 10,000 women who are pregnant and say, hey, we'd like to put you in a study and give you the vaccine, see if anything happens to your baby. It's going to be people who got the vaccine, didn't realize they were pregnant, or who got the vaccine, knew they were pregnant, but were willing to take the risk. And eventually they'll have some data. But I can't see it being a problem.
Sorry to interrupt. Same thing for breastfeeding women. Like it's recommended to do it, but you know, there's going to be no data for.
Yeah, no data. That's exactly right.
Breastfeeding and the effects on the baby. But
if you have one, what's that? Marilyn, what's that word you typed there? Antiphilic.
Should be probably anaphylactic.
Anaphylactic. Okay, yeah, that's right. One anaphylactic reaction 40 years ago, possibly to aspirin. Should I be more careful when I get the vaccine? When you go in, you should say that you had an anaphylactic reaction to aspirin Anyone who's giving the vaccine should have adrenaline available for treatment, and you're supposed to wait 15 minutes. You could wait 30 minutes, and they should be ready to treat you. You should get the vaccine. You could potentially, you could try pre-treating with an antihistamine. I don't know if that would make any difference at all. There's no aspirin in this. There is the propylene glycol. So it's hard to know whether you're going to have a reaction, but I would say tell them that you have a history of anaphylactic reaction. They'll watch you more closely. So
John, I just have a,
just to go on that, they should not be giving it any place where they can't treat an emergency, basically. Yeah. I'm sorry, go ahead, whoever that was.
John, can you just clarify, if you've had the vaccine, you've had both shots, you still can be carrying the virus, but are you carrying less of it? Are you less of a danger to your grandchildren?
You still carry, you can still carry the virus. Theoretically, you'll have a lower viral burden, but we don't know that for sure. If you have antibodies that look, here's the thing, if you've had a COVID vaccine infection and been treated, you still can carry the virus in your nasopharynx for like 6 weeks afterwards. We don't know if you're actually infectious. We allow you to go out about the community 10 days after your first symptom because you seem to be less infective. So one could then say probably, since when you get the COVID infection, you develop antibodies, probably if you get the vaccine and you have the virus in your nose, it's probably less likely to be transmissible, but we don't know the answer to that. If you got both of the vaccines and you're wearing a mask and you're around your grandchildren, I suspect it's reasonably safe, especially because small children have a lower rate of infectivity. So you can weigh the. If you have a child who's got an immune system problem or heart problem or a lung problem, I would say don't take the risk. But if you have an otherwise healthy child and you've had both vaccines and it's been a few weeks and you're wearing a mask anyway and keeping your hands clean, the risk is pretty low.
Have an immune system, like a child with that system.
I can't hear what that was.
I think that was background noise.
So what
Can I ask your opinion on something, John?
I have an opinion.
The controversy between whether school should open or not. What would you say the criteria is?
I think it has a lot to do with the prevalence of infection in the surrounding community, because the kids seem to have a very low level of transmission among themselves. What the problem is that they can bring it home to their parents and grandparents. So I'll tell you what we did with Kaylin, my stepdaughter. We took her out of in-person school for this particular trimester because I felt like the prevalence of infection both of us felt the prevalence of infection in the surrounding area was high enough, and people were careless enough about masks that children could bring it in. We knew we'd eventually get the vaccine. We didn't have it at the time we made this decision, but we didn't want to transmit it to Kellen's grandparents. So now we're seeing that the prevalence rates are dropping off. It seems to be safer. There's not the kids showing up all the time with illness. We have now talked to the school, and starting in March, we're going to send her back to in-person school, just because the rates are getting lower. So that's really where the decision has to be made. What's the rate of infectivity? What's the prevalence of the disease in the community? Ideally, the school boards would be making a good decision based on that, but it seems to be working out okay for in-person school at this point. And go back to September, October, we really didn't know where things were going to be going, and so people made a decision that was a little bit more conservative to avoid problems, but they're tracking it pretty closely. So I feel at this point that you could probably go back to in-person school. Now they're going to have to wear a mask. They're going to have to be as socially distant as they possibly can. They've got to keep their hands clean. That's always a problem with young children, to make sure that to to keep that, keep a real strong control over that. But it's looking like it's reasonably safe for kids. It may not be the same thing for adults, but give it a little more time.
It's getting close to 10 o'clock. Is there any other questions? We have 1 or 2 minutes left.
So summary, just keep an eye on the Department of Health website, check the Penn State website. There should be more information over the next month as to where to get a vaccine started. You can premeditate if you're worried about side effects, and it's okay for you to take those particular medications and continue to wear your masks and avoid people who don't have the mask on correctly.
Thank you very much, John.
You're welcome. Good to see everybody. Hope
Thank
this
you.
all
Yes,
ends
thank you
perfectly
very
soon.
much.